Good afternoon, everyone. I want to thank you for joining us today on Monday, January 11th. We appreciate your time. We know it's a very hectic time. We are pleased to join here with Alameda County Public Health Department and Ombudsman Services to provide you a weekly update of what is going on as it relates to COVID in the county's long-term care facilities, as well as provide you an update on information just unfolding in general. So as a reminder, we are recording today's webinar. We will send you the slides and the webinar and any additional materials that we discuss at the end of the day. Please, this is an interactive session, so please be sure to drop your questions and any additional information in either the chat or the Q&A. And with that, I'm going to turn it over to David. David, are you there?
Yes, I am. Can you hear me?
Yes, we can.
And you can see my screen okay?
Can, absolutely.
Okay, great. Well, welcome everybody. Thanks again for joining us on this Monday afternoon. We're all as busy as you are, but you're the ones out there on the front lines, and we really appreciate all the efforts you're making to keep your residents and staff safe. So let me get into some slides, and then hopefully this will spur you to ask some questions in the chat or to simply unmute and ask a question. So let's see here. There we go. So let's talk a bit about the vaccine planning and prioritization. Here's a slide that Dr. Clannon and Dr. Doe shared last week to all the long-term care facilities, or excuse me, healthcare facilities here in Alameda County. As most of you know, you're falling into this group that we call Phase 1A, Tier 1. And so we're working hard to be able to get enough vaccine to cover all of the workers and residents that fall within this Phase 1. And this is not any small task, as you can imagine, in terms of the doses, the scheduling, the setting up of pods, and to make sure that people don't skip to the front of the line ahead of individuals that are in Phase 1. So we are working hard to create every opportunity to meet the goal of vaccinating everyone in Phase 1 in a timely manner. And certainly the individuals on this call fit in that category. So just a little bit more of who's in Phase 1. And as you can see here, early on, the FDA did kind of identify recommendations of who should be prioritized, and then the states were allowed to interpret those recommendations and make their own recommendations, and then counties as well could weigh in. So just like everything else when it's come to this pandemic, this is very much a local response, and that's why you will see different counties engaging in different activities in order to meet the goal of vaccinating everyone who's in Tier 1, Phase 1A. Most of the facilities, as you know, here in Alameda County are a part of the Federal Vaccination Partnership Program with CVS and Walgreens. And for the RCFEs and other assisted living providers, adult residential facilities in Alameda County, CVS and Walgreens will be reaching out to you directly to set up your first clinic. If you feel like you don't remember signing up for this federal partnership, it's okay, because the California Department of Social Services signed up pretty much all the facilities that they are responsible to regulate and license. The very first clinic in our skilled nursing facilities began on the 28th at Garfield Neurobehavioral. And so clinics have been happening with our skilled nursing facilities, and they're really were the first priority for CVS and Walgreens. The very last SNF first clinic will be held on January 29th. So it will take one full month for CVS and Walgreens to complete the first clinics at 70 of the nursing homes here in Alameda County. CVS and Walgreens is planning to schedule clinics at 250 different long-term care facilities in Alameda County, representing over 18,000 beds. Of course, certainly there are not 18,300 residents in those beds, as occupancy and census is way down across all the different long-term care facilities. Other long-term care facilities are starting to have vaccine clinics scheduled. And please, if you are an RCFE or an assisted living provider, adult residential, board and care, and you're listening in on this call, go into the chat and let us know if you've heard from CVS and Walgreens and if your first vaccine clinic has been scheduled. We'd be very interested in knowing if you've already had a first clinic scheduled. Thank you. So if you want more information on the logistics, certainly go to the website. If you're not clear whether or not you're signed up for CVS or Walgreens, please reach out to myself or Renee, and we'd be happy to check the list for you so that you can reach out to the appropriate federal partner. Only about 60% of the staff in skilled nursing facilities are accepting the vaccine the first time it's offered. So this is what we anticipated, that staff would have some hesitancy and concern about being the first to go. However, we're seeing some of this being diminished as more and more individuals are getting vaccinated and reporting very few adverse events or side effects. For the most part, a tiny percentage of skilled nursing facility staff have called out ill after being vaccinated, a tiny, tiny percentage. For the most part, people just have a sore arm for a couple of days, but nothing to call off from work. However, you know, if your clinic hasn't been held yet, it's really important that the leaders on this call work hard to overcome vaccine hesitancy by hearing people out, discussing some of their concerns, and anticipating some of the questions that they're going to ask. And so some of the best practices are to hold town hall meetings, listening sessions, so that you can respect and honor and value people's feelings about the vaccine, and then deliver some factual information if you're hearing that they're getting information from unreliable sources. If you really want to have a successful vaccination clinic, you really have to do this pre-work in order to get a high number of residents and staff accepting the vaccine the first time it's offered to them. About 95% of residents are accepting the vaccine the first time. Only about 60% of staff are accepting the vaccine. So please help carry out the message. Make sure if any of your staff who've already received their first dose, if they can serve as a spokesperson for you to convince others to accept the vaccine when it's offered to them again. Set a goal. 95% of our residents and staff will be vaccinated after 2 clinics would be a very reasonable goal to set. But certainly we don't want to have the opportunity to have people vaccinated and have a small percentage who accept the vaccine. That would be a real disappointment for all of us. So in order for your clinic to go smoothly and in order for your vaccine clinic to lead to a high number of people being able to be vaccinated during that 8 to 4 time frame that CVS and Walgreens usually offers, make sure that you're well prepared for their arrival. Make sure that you have some dedicated staff to support CVS and Walgreens. Make sure that you've set up their clinic space in an appropriate way. Some of the common themes that skilled nursing facilities have run into that have led to delays and issues that have led to fewer individuals being vaccinated is if you don't have the consent forms completed and in alphabetical order and right in front of the vaccinators when they arrive, if residents are missing their Medicare cards or other information around their insurance, that will lead to delays. And of course, if you're experiencing an outbreak, Your clinic will still be scheduled. However, many staff, of course, will be unavailable to assist. So you're going to have to work around that. But your clinic will still be scheduled even if you're having an outbreak. Some of the common themes of successful vaccination clinics with Walgreens and CVS are these, that you did a lot of work ahead of time to communicate with staff and residents, so a high percentage of them would accept the vaccine at the first clinic. That you have all your paperwork in place and the consent forms are complete, and that you have adequate staff to support them. And those would be some of the common themes of success that skilled nursing facilities have experienced in working with Walgreens and CVS during their first vaccine clinic. I just want to alert you to a pin that came out a few days ago, another vaccine informational call being held by Community Care Licensing Division. Here it is. Here's the information. I invite you to join any type of informational call related to the vaccine. And here's the next one offered by the Department of Social Services. So Alameda County, just like many other counties, is working and drafting strategies to try to vaccinate long-term care facility staff and residents faster. And to do so, we plan and are already collaborating and communicating with CVS and Walgreens about some of these various strategies that you see here that would speed the process along. And each one of these strategies has already either been utilized or employed at various states or other counties already. And in some cases, we've already utilized some of these strategies with some local providers. So just very briefly, some of the things that we're working on are partnerships with local pharmacies that we can reallocate doses to, who would then go out and have clinics at long-term care facility provider sites. We're talking to some of our testing providers, our mobile testing providers, about converting them to mobile vaccination providers. We are willing and able to reallocate doses to providers who have the clinical competency and the approval and CALVAX to accept our doses, that they can vaccinate their own, and we've already done that with a few facilities. In addition, we're working with Kaiser to see how we can reallocate doses to them so that they can offer the vaccine to KP members who are long-term care facility staff. And the final strategy is something that may come to fruition quite quickly, maybe as soon as next week. And that is the hope that we can invite all of the long-term care facility staff in Alameda County to an Alameda County vaccination pod or two, so that you can get a bunch of your staff vaccinated before Walgreens and CVS comes around with their clinics, which would be ideal, because then if, let's say, 30% of your staff went to a pod and got vaccinated, and then you had a clinic, you'd have a good foundation of people convincing other staff to accept the vaccination at your first clinic. And ideally, what we want to do is offer the opportunity for long-term care facility staff to come to a vaccination pod so that we can get as many of those staff members vaccinated quickly, even if it's well ahead of the planned clinic with CVS and Walgreens. Because we know, based on the research, that staff many times who are asymptomatic unknowingly bring the virus into our facilities. And to the extent that we can vaccinate the staff as quickly as we can, we'd like to do so. So I think I'll pause right there and see if there's any questions in the chat before we move to a different topic and we close out this topic on the vaccine.
So many questions, David. I want to start with a good one. Someone telling us that they have the first clinic scheduled for the 14th with CVS. So that's great news.
That is awesome news. I'm so pleased to hear that.
Now, some folks say that they don't have a schedule, but they've at least talked to CVS. And another person says, I've talked to them about 2 weeks ago, but I haven't heard anything from them since. And so I just want to reiterate, please participate in the call with CDSS scheduled for this Wednesday. I suspect they're going to have an update for us. And I think it's also really good. There's generally have an opportunity to ask questions. And so if you're having questions about the partnership, that would be a great place to bring them, particularly for those of you that have not been contacted or have not been scheduled at this point. I know David and I are working really hard to get the word out of the need you guys are experiencing. And if you could join us in that, it would be really appreciated.
Yes, but it's really encouraging to know that CVS is already reaching out to you and scheduling clinics as soon as January 14th. We were concerned they wouldn't schedule their first ones until the end of the month. So that's good news. It means that CVS and Walgreens is hiring up and staffing up to be able to offer more clinics.
Excellent.
I see a question here. How should long-term care facility handle new residents who enter their facilities after the vaccine clinics? Will new residents be required to have a vaccine? Generally, no. You should continue to accept new residents, even if they haven't been vaccinated, after you've had a clinic. After all, nothing's going to change after your first clinic. You'll still have to wear masks. You'll still have to admit new residents from higher levels of care with consideration of whether or not they've been exposed, and if so, they'd come in under quarantine as a yellow status or in the yellow zone. So really nothing like that is going to change, and you certainly don't want to at this stage say, hey, we'll only take new admissions who've been vaccinated. That really wouldn't be the right thing to do right now. So please consider just keep admitting, and for the new admission, when your second clinic is scheduled, they can get their first dose at that time. I see Jocelyn says we have a clinic scheduled for January 17th. Awesome. And, there may be a few facilities that somehow didn't get onto the federal partnership program. And here at Alameda County, we're aware of those providers, and we're going to serve as their needs if Walgreens and CVS does not. Do you see any other questions?
I do. Just a question here. Some providers work in multiple counties. And so their question is, will they be contacted by individual pharmacies for each of their facilities in each county? Will it be a general contact to get all of their facilities done?
No, the CVS and Walgreens is treating each individual provider as a standalone entity. So they're not, contacting a corporate office that owns 5 residential care facilities. That's not how they're working it. They're contacting each facility and scheduling their clinics that way.
Excellent. Now, before we go on, David, can you go back to the slide which has the toll-free call-in number for the call this Wednesday with CDSS, and I will drop it in the chat. Just stay there for 1 second.
Sure. And while she's doing that, for all the adult senior care and program licensees, remember from the California Department of Social Services, PIN 2048 that came out on Christmas Eve, your COVID-19 mitigation plan is due January 24th. So don't forget about your COVID mitigation plan due January 24th.
Excellent. Everyone, I dropped this information in the chat. And again, it's this Wednesday at 1 o'clock. So please put this on your calendar. We hope you'll join us. And Dave, with that, I think you can go on to the next section.
Yeah, I'd like to talk now about strategies to stabilize staffing. Many of us face really critical staffing shortages right now, and if you're having an outbreak, certainly that can play out. But there's things that we can all do in order to prevent and mitigate staffing challenges as they relate to an outbreak. So here's a couple items and best practices to keep in mind that is titled Ways to Stabilize Staffing Before the Outbreak Spreads. So here you are, your leadership team, and you just learned that 2 staff members have tested positive. Okay, so we got 2 staff. Your thinking should be, okay, this is probably going to lead to 5 residents turning positive. That, you know, I don't mean to be a doom and gloom, but that really should be how you're thinking, that 2 positive staff is going to result in positive residents, and we need to get ready for that, and we need to stabilize the staffing before that occurs. So best practices, talk about this with your leadership team immediately, as soon as, well before you have a positive staff member or resident, but if you have one, this should be the immediate emergency discussion of how we will stabilize staffing. Because if you can't stabilize staffing, it's really hard to mitigate the spread. And when staffing kind of implodes, we do see a more widespread spread of the virus. Number 2, let all the leadership team know and the frontline staff know that if the outbreak is widespread, that staffing can completely fall apart unless we act now. And we've seen this play out. Number 3, look closely at what incentives you're offering staff to work during an outbreak. What kind of hazard pay are you offering? What kind of sick pay? Do you offer quarantine pay? Are you going to offer hazard bonuses? How much exactly? Is it competitive? Because, you know, you really have to step up in the corporation that owns you or your ownership team. You got to step up for the 2 weeks that you're in this crisis. And if you're trying to kind of shortchange folks when it comes to hazard pay and bonuses and quarantine pay, that's when you exacerbate staffing challenges. So it's really wise to kind of up the ante, if you will, when your outbreak begins. Maybe double the bonuses, maybe double the hazard pay, but you're going to have to do something because all the providers around you are doing something, and you need to stay competitive. Number 4, how stable is your staff now? I mean, how many open positions do you have right now? Because if you already have 10 open positions and your outbreak hasn't begun, then you can predict that things are going to get dire quickly. However, if all your positions are filled and you have a really good culture and good communication, and you're taking care of things ahead of time, then you can help mitigate some of the staffing challenges that you should anticipate. And finally, and maybe most importantly, after you've done this pre-work with your leadership team, you should meet with all of the staff and let them know that a widespread outbreak is probably likely, and that you would need staff to volunteer to work in the red zone. So I'm sorry that got cut off, but you need staff to volunteer to work in the red zone. So you want to gather all the staff together and say, hey, we're likely to have residents turn positive, and when we do, who's willing to volunteer to take care of them? And when you get those volunteers, it really helps attendance over the next 2 weeks, because then you can convey to all the other staff who didn't volunteer that they will not be asked to work with the positive residents. So that's a really critical step. And if you were to take this step, you help to stabilize staff. The leader should also be honest and say, hey, you know, some facilities experience mass call-outs when they hear of a positive resident or 2, and you know that can't happen here. It should be your message. How can we make sure that that doesn't happen here? Because you know, if we're donning and doffing the right PPE correctly, you should not have fear, right? If we already have volunteers to work with the red zone patients, or residents, then you should not have fear of working in the green zone. So you really want to be transparent with the staff and say that we anticipate call outs. Let's talk about how we prevent them together before they occur. Long-term care facilities leaders should also ask all your non-direct care staff that you'll need them to help to volunteer to take care of residents when the crisis staffing occurs. So I'm talking about laundry aides, housekeepers, receptionists, office staff, admissions staff. Everybody and all of them should be asked if they would be willing to take care of residents, or at the very least, help the nursing staff with some of their duties so that they can direct all of their time and energy to caring for the residents. As many of you know, we have nurses and frontline caregivers who engage in a lot of activities that have really nothing to do with caregiving. And so to the extent that laundry aides can help deliver trays, that housekeepers could sit with and help calm down an agitated resident who is living with Alzheimer's disease. You really want to kind of huddle with that group ahead of the outbreak too, and be very clear that you're going to need their help beyond, kind of their job duties. I know the administrator at Garfield. He worked as a night shift CNA for 8 nights in a row during their outbreak, and he's not a CNA, never been trained, but he had to do it. And that's kind of what I'm saying here, is that when it comes to crisis staffing, all hands on deck. Any willing individual who would help with caregiving tasks should be allowed to help. Okay, so let's talk through now when you're allowed to let individuals come back to work who should be on quarantine, and when you're allowed to let individuals come back to work who've tested positive. So let's refer to PIN 2043 for RCFEs and other long-term care facilities that came out on December 1st. It says that RCFE facility staff who have COVID-19 symptoms must isolate at home and follow guidance in the PIN regarding when to return to work. So in all cases, whether it be a SNF and CDPH or a PIN and RCFE, in all cases, symptomatic people can't be in the facility at all. Symptomatic people are shedding the virus or some sort of virus. So anyone with symptoms, this really doesn't apply to them in terms of returning from quarantine or returning after testing positive. So just keep in mind, symptoms can't work. Go home, isolate. But for facility staff who are essential to the facility operation, like many of you and your staff are, who've been diagnosed and tested positive but are asymptomatic, may be permitted to continue to work with residents diagnosed with COVID-19, provided they remain asymptomatic, wear a respirator, surgical mask, gloves, the whole deal, right? So they can come back and work with residents diagnosed with COVID. In addition, our own health order at Alameda County came back out on the 24th. So, geez, another health order or information coming out on Christmas Eve. So you may have missed this, but we in Alameda County also helped clarify kind of these issues around when people can come back to work. And in our health order, it says that during periods of critical staff shortages, which many of you are encountering, healthcare and emergency personnel who work face-to-face with residents in assisted living facilities may return to work after day 7 from the date of last exposure if they received a negative test result from a PCR test performed after day 5. So as many of you know, you work with staff. Let's see that the husband tested positive and the wife, who's your LVN, has to quarantine for 14 days. So here, our health officer order is saying your nurse doesn't have to quarantine for 14 days. She can cut it to 7 as long as she gets a negative test on day 5 and she can come back to work on day 7. And for purposes of this paragraph within our health officer order, it talks about critical staff shortages occur when there are no longer enough staff to provide safe patient care, and the shortages cannot be alleviated absent the return of otherwise quarantined employees to work. And for many of you, you're falling under this umbrella of critical staff shortages, which enable you to bring staff back early. So if you bring them back early, again, the person has to be asymptomatic. They can provide direct care to patients. They have to, let's see. So yeah, they can come back to the 7-day strategy, but here, that third bullet. So the third bullet, I got clarity on this one. This third bullet means that your staff, if you're in this crisis staff shortages, then you can actually bring staff back after day 1, 2, or 3 under quarantine, according to our health officer order, as long as you just keep testing them over and over again. So that's what that third bullet indicates. So once again, if you have exposed staff, as long as you're really aggressively testing them, they can return to work and help you if you're in a crisis staffing situation. So what makes it a crisis level? Oh, we talked about this a little bit. We talked about triggering your crisis staffing plan, which means engaging dietary, housekeeping, EBS, laundry, office staff, drivers, all of them, to assist nursing so that the residents are kept safe. And of course, ahead of time, you can identify all of the tasks that these individuals can perform that aren't direct patient care related, that take a lot of pressure off the caregivers, such as changing beds, delivering food trays, sitting with agitated residents, leading small groups in the green zone, cleaning rooms, moving residents, calling families, connecting residents and families through virtual visits, all that stuff. Any pressure that you can take off the caregivers, this is the pressure, that the items and tasks that you can divert away from them. And then as a last resort is decompressing the resident census. That's the last thing that we want to do, because transfer trauma is real. And when we start moving residents around, they suffer from that. So we might be perhaps decompressing the facility due to staffing issues only to exacerbate the conditions of the residents being moved. So I think I'll pause there. After this section related to tips around getting staff back to work and the guidance that supports it. Any comments or questions about this section?
David, we have a really interesting question, which is, if you have a staff member who has had close contact with a positive coworker, but that positive coworker is asymptomatic, can the staff member that had contact with them still continue to work? Like they don't have a positive yet. The other person has a positive, but they're asymptomatic. Can the person who contacted them still work?
Yes, according to bullet number 3 in our health officer order, they can, as long as they're consistently being tested, as long as they're consistently following strict infection control protocols. And even if you're not in crisis, they can. Even if you're not in crisis, they can return after day 7, as you can see here, as long as they test negative on day 5.
And so can you remind everyone how frequently should staff of residential care facilities for the elderly be tested for COVID-19?
Well, right now our county positivity rate is 9%. So that's very, very high, and in some zip codes, it's over 9%. According to our last health officer order, as it relates to testing and long-term care facilities that aren't skilled nursing facilities, Facilities who are 6 beds or less should be testing 25% of their staff each week or 100% each month. For those that are 7 beds or more, you should be testing half your staff every week so that you test 100% of them every 2 weeks.
And so if we were to go back to that scenario where a staff member had contact with another staff member, but that was asymptomatic, are there any differentiations of when that happens? So for example, what if a staff member lives with other people at a home, and so they had extended contact with a group of folks who end up being positive? Or is it just sort of really quickly in the hallway as they're saying goodbye as their contact? Is there any different way in which you treat that scenario?
Well, the definition of a close contact is pretty tight. At the very least, it's 15 minutes of close contact, and that 15 minutes could be the cumulative 5 minute here, 5 minute there, 5 minute there over a 24-hour period. So it doesn't really take a lot of contact or time to be considered a close contact with someone who's positive. But generally speaking, if you're, allowing someone to come back early, like our health officer order is allowing here, you'd want to be advising, the husband or wife or housemate to certainly separate from one another to the extent that they can, use different bathrooms, and stay apart for their quarantine or isolation period to the extent that they can.
Mm-hmm. And so Stephanie asked, that they had been told previously not to test someone who tests positive for another 90 days. Is that still in effect, or is that changed?
No, that's still the case. Yeah, you don't have to test people who tested positive in the past. So there's a high likelihood that a PCR test is just going to keep picking up very small evidence of the virus in your system. It's just not necessary. So if someone has tested positive, went into isolation, came out after day 10, they're considered COVID recovered, and you don't have to test them again for 90 days.
Excellent. So just want to encourage everyone to drop their questions in the chat or the Q&A, but there's no more at this time, David, if you want to go on to the next section.
Okay, so let's just talk a little bit about an infection control like we always cover during this webinar. For many of you, you know certainly how this is spread, and you're hearing about variations of the virus that is leading to perhaps even greater spread. But without a doubt, I think we're clear on how this is spread. And hopefully by now you're well aware of the core principles of COVID-19 infection prevention. Hopefully, all of your staff is well aware. But there's a lot to each one of these bullets, as you know. We're going to cover just a couple of them with our remaining time. So for the most part, as you recall, the most important thing that you can do is act quickly on any data that you have, whether that be that you're screening individuals and you found a resident with a change in condition, you'll want to act quickly, or if you have a positive staff member, you're going to want to act quickly. But moving quickly is key. And really, the research shows that the faster that you can engage in response-driven testing after the first positive, the greater the likelihood that you'll be able to mitigate the spread. If after your first positive, you don't engage in widespread testing for 3 or 4 days, there's a high likelihood that the virus has already spread. So immediate action is required. So even though testing is absolutely the best way of screening whether or not someone has COVID, we still have to do symptom checks. We still pick up positive people by checking on their symptoms. And for anyone over the age of 75 or 80, sometimes those symptoms show up in very subtle ways and kind of unique ways to an elder. So an elder who starts falling, who didn't fall in the past, you should be thinking, oh, they might have COVID. If someone an elder is really agitated and they're usually very positive, you should be thinking, let's test them for COVID. So any change in condition, you want to consider that perhaps that is the body telling us that this person has contracted the virus. A new study just came out today from the Journal of American, or JAMA, I should say, and it puts the number at 50%. So it's indicating that 50% of residents with COVID-19 are pre or asymptomatic. So once again, just points to the necessity of combining monitoring for symptoms with testing is the only way to know. It's the only way to know. So for the individuals on this call, even if you're testing your staff, half the staff once a week, and you're meeting the health officer order of test staff once a week, this study would say to you, well, if you only test the staff once a week or half the staff once a week, you're going to miss half of the individuals who are carrying the virus who are asymptomatic. So once again, I just want to encourage you that 50% of the staff being tested a week is probably not enough. That's what our guidance is, and that's what the health officer's order says. But if you look at this research and you figure how much you're testing, you have to assume that you'll miss half the cases unless you test 100% of the staff every week. So remember, here's our testing kind of summary. We got the testing trigger, when to test staff, when to test residents. So of course, anyone with symptoms, test them right away. Send staff home and test them right away. Isolate residents. Anyone with symptoms, we isolate no matter what. If you're having an outbreak, we're into response-driven testing, and you'll want to test all of the staff every 3 to 5 days, and you'll want to test all the residents every 3 to 5 days. Of course, these are only the residents and staff who tested negative in the past. You don't have to test people who tested positive in the past. And then if you're not in an outbreak, as we discussed earlier, there's the cadence for testing the staff if you're 6 beds or less or 7 beds or more. The CDC and other entities do not recommend that you routinely do screening testing on all of the residents. It's just not necessary. But it's important that you screen a small portion of the residents who maybe went out for New Year's Eve parties or go to dialysis every other day or once a week, or they went to the emergency room. These are individuals that it would be very smart to do some testing on them just to make sure. So in our final few minutes, let's just talk about managing the environment and keeping it clean of the virus and how it might spread in a facility. I'm sure that for many of you, you've hopefully beefed up your housekeeping staff, and you have dedicated housekeepers and other EVS staff who are simply going around and cleaning high-touch areas. And hopefully they're cleaning them with the right products that will actually kill this virus. And so we have an EPA list, it's list number N, of the specific chemicals that have to be used to kill this virus. And if you go to the EPA website, you will find, if you look on the right-hand side of all the lists, look at the very bottom, second from the bottom, list N, disinfectants for use against SARS-CoV-2. That's the one that you click on, and that would really be the only list that would comprehensively give you the exact products that you would use that would kill this virus. So 6 steps to effective disinfectant use: always clean and then disinfect. Always clean and then disinfect. I want you to tune into step number 4 in the 6 steps, because this is really important. A lot of housekeeping staff, they've never really had to tune into the contact time, which refers to the time that you would leave a disinfectant on the surface to give it time to kill the germ before wiping the surface. So many skilled nursing facilities have gotten lots of deficiencies as surveyors have watched housekeepers ignore the recommended contact time for the disinfectant. And it's really important that you follow the recommended directions of each disinfectant approved for COVID disinfecting, to make sure that you're leaving the disinfectant on the surface long enough to kill it. So there's also good guidance around if your residents are sharing medical equipment. And generally speaking, you want to use the same approach, cleaning and then disinfecting, making sure you're disinfecting only with those approved disinfectants, EPA list N. And the new rule generally is if you are using medical equipment between residents, the person who finished using it, the equipment would be required to clean and disinfect. And then any individual caregiver who grabbed the equipment to use on another resident would also be required to clean and disinfect before the use. So as long as we kind of have our caregivers tuned into cleaning and disinfecting after, cleaning and disinfecting before, then we should be able to keep our residents safe. So we covered a few topics today: the vaccine, handling staffing crisis situations, and cleaning and disinfecting. So open in the few minutes we have left to any comments or questions around any topic.
While we wait for some questions to pop up, I just wanted to share with you, and I will email this out as well. I'm just going to stop your screen sharing just for 1 second, David. I just want to share with everyone some additional training that is coming up from the Alzheimer's Association and the Family Caregiver Resource Alliance related to LGBTQ and dementia. They have a training on the 18th, and then they have part 2 on the 25th. And again, we will send out the link and the flyer with our follow-up materials. But they asked me specifically to reach out to long-term care facilities, saying this was an ideal fit for all of you, and to opportunity to train your staff on how to better work with individuals who experience a dementia and are from the LGBTQ community. So I just want to highlight that for you on the screen and let you know that that's one of the flyers you will see in your follow-up information. Again, I want to invite everyone to drop their questions. This was a lot of information. Thank you, David. A lot of important things to learn and to think about today. Also, if you've had any best practices around some of these topics, I know David talked a lot about staffing and how to prepare for surge staffing. So if you've had luck in a certain area or you have tips to offer, those are also really welcome. Please add those to the chat.
Yes, please. Thank you. And anyone can take themselves on mute and ask a question, right, Nicole?
I don't know that it works like that. I think they could raise their hand, but again, also dropping in the chat or the Q&A. I'm so sorry. I'm not a Zoom webinar expert, but I'm learning.
Good, thank you. Okay.
I'm not seeing anything come in.
Okay. Well, that's okay. We can give everybody 10 minutes back.
Excellent. Well, just to remind everyone, we will send this and any other additional information that David has mentioned today, along with the LGBTQ dementia training, out to you likely early tomorrow morning. We will be here again next week. And as the situation unfolds with vaccines, I'm sure we'll have an additional set of information. We want to encourage you to participate in the training on Wednesday with Department of Social Services. As a reminder, if you'll scroll up or higher in the chat, you can see the passcode and calling number, and it will also be displayed on the PowerPoint when we send that as well. So I want to thank you all for coming. Well, I hope everyone has a great week. David, any final words for today?
Nope, just like to thank you all and really encouraged that we're so focused on the vaccine, and I know you are too. So we can just get through this really difficult period. We have this light at the end of the tunnel. So thank you all.
Absolutely. Well, we'll see everyone next week. Have a great week, everybody. Bye-bye.